So my name is Caroline Taylor. I work alongside Celtic SMR. So it's my pleasure to be able to introduce, to thank Celtic for being able to host these sessions on different uses of laser for our veterinary patients to try and improve the use of laser in particular, but also just the offer that vets and vet physios and veterinary nurses are using within their practice. So we have Rachel Rowe with us this evening, who has produced this super presentation about how she manages MSK compensatory mechanisms, particularly after cruciate surgery and TPLO surgery using MLS Laser. So Rachel qualified from Glasgow Vet School way back as an RVN, and after that she actually went on, after she graduated, she actually went on to Nottingham Vet School and graduated with distinction in physiotherapy back in 2010. And Ayrshire Canine and Equine Physiotherapy was born.
So tonight's chat, we're talking about management of compensatory musculoskeletal issues, primarily post cranial cruciate ligament injury and TPLO surgery. And we are doing a talk later in the year about laser management of cruciate injury and TPLO TTA surgery. So that's to come later on. So just to make it very clear, I thought I would put a learning slide in. So today, I'm hopefully by the end of the session, you're going to understand what compensatory factors are and how to treat them, treatment protocols for laser application, and a physio approach to management. I want you to start thinking at this point about the animal globally, rather than just concentrating on the stifle joint. So that's the kind of underlying theme for tonight's chat. What causes an animal to compensate? I've put in here a direct lift from the dictionary. Compensation is the correction of an organic defect or loss by hypertrophy, counterbalancing, or by increased functioning of another organ or an unimpaired part of the same organ or other structure. And again, this is where I come back to the global approach. If you hurt your big toe, you're going to have compensatory issues going up your limb to your buttocks and then crossing over laterally to the opposite side of your back. So I just want you to start thinking globally about compensation. So pain, muscle and fascia dysfunction, surgery, trauma, injury and wound, inflammation, reduced mobility, muscle hypertrophy and atrophy, so muscle wastage, loss of function, neurological impairment. When we think about pain, we first of all, as clinicians, need to understand what is the dog's normal baseline for pain. So how much pain can that animal tolerate before it starts compensating? And we see this all the time in practice. You know, some border collies that I've had through the surgery are grade 7 agility dogs, and they've had a fall off a piece of equipment. And we think initially it's a soft tissue injury. They come in, we treat it as such initially. The gait pattern doesn't improve. We refer them for further examination by the registered vet. And lo and behold, the dog has got hip dysplasia and it's been hip dysplastic for years and nobody knew. And that dog has obviously been dealing with an underlying pain factor throughout all that time, yet it's continued to train and perform at a very high level. So there are some dogs that will have pain management under control and some that won't, just like in humans. You'll have those that can deal with pain and wusses that can't. We've got muscle and fascia, or the myofascial unit dysfunction. It has both a physiological effect and compensation, and also a pain factor comes into that as well. If the muscle or fascia isn't working or activating properly, or the muscle's too weak to perform a task, then other muscles and fascial connections and joints and other organs of the body have got to take over that role, and that then leads to compensation. We've obviously got surgery, which we're talking about on a kind of lateral aspect today with CCL or trauma or surgery. We've got the initial wound post-surgery and the underlying injury, and how long the animal has carried that injury prior to it being identified. We all know that cruciate ligament strains can happen before a complete rupture, and that animal may very well have been limping for a number of weeks, if not months, prior to the CCL either rupturing or the dog being attended to by a vet and a confirmation of diagnosis performed. So again, that dog then has been counterbalancing and compensating for a number of weeks or months, which will cause dysfunction and potential injury in other parts of the body. We've got inflammation, which obviously we all know about, acute and chronic inflammation. And again, that ties into the original injury, how long has the animal been carrying that injury, and then obviously acute inflammation from surgery. We've got reduced mobility, and that comes from obviously an altered gait pattern. The altered gait pattern can be a transverse gait pattern coming from, for example, if the dog's right hind CCL is giving it bother, then it will offload to the left fore. However, if there's an issue, an underlying issue in that left fore to start off with, perhaps it's got elbow dysplasia, or it's got arthritic change in a carpal joint, or there's another soft tissue injury, then that animal will offload the left fore onto the right fore, and so on and so forth. We've got muscle hypertrophy or atrophy, which is obviously muscle wastage. We know that muscle starts to atrophy approximately 3 days post non-use, and we see a lot of dogs pre-surgery and post-surgery with gross or severe muscle atrophy on the affected limb, and that obviously makes the dog compensate through gait pattern and obviously offloading and hypertrophy on other limbs. We've got loss of function, so the dog could quite simply be non-weight bearing on the 3 legs, and obviously compensates for that gait pattern, and neurological impairment. And that goes from a sort of micro world of mechanoreceptors and Golgi apparatus right up to neurological damage or neuritis and proprioceptive deficits. So, and that's, I'm sure there's lots of other reasons why animals compensate, but that's just the kind of major ones that I have introduced in this slide. So compensatory factors include, we discussed this just briefly a wee second ago, abnormal gait pattern. And we've all seen the dogs that present with wide base gaits behind, and by that I mean the hind limbs are distorted from the normal gait pattern. We've seen dogs that are exorotating a hind limb or circumducting a hind limb, not foot planting properly, so toe touching or planting the heel, animals that are dropped through the hock, animals that are hip hiking or hip swaying. That obviously then has an impact on their spinal musculature and the rotation of the spine. This then comes forward to the forehand, where we've got issues with the forelimbs, and quite often we'll see it in horses as well, where a dog will have a hind limb lameness pattern, and it will then start limping or be lame on a forehand leg as well, so on a thoracic limb as well, due to the stresses and strains put upon it. So I think that about covers the abnormal gait pattern. We've got secondary issues and injuries. Again, we touched briefly on this in terms of does that animal have any other joint issues that we need to be concerned about? So is it the first cruciate ligament that's ruptured or that it's had an issue with, or does it have CCL disease? Are there any degenerative joint issues? So are we looking at secondary arthritic change? Are we looking at underlying arthritic changes that are already present? And then it goes on really from sort of joint issues to other skeletal issues and soft tissue injuries. Were the soft tissue, was the muscle function correct before the injury? And has it now got a soft tissue injury in front? For example, we quite often see with CCL dogs, pre and post surgery, we can have bicep tendon issues on the forehand from offloading. We can have interscapular issues. We get lots of trigger points, caudal border scapula, and cranial shoulder girdle musculature. So these are things to sort of have a think about on how the animal's moving and how it's loading and offloading. Post-surgery. So initially post-surgery, we've obviously got wound, we've got wound management, we've got inflammation, initially acute, then progressing to chronic, we've got pain. The other thing which I have personal experience of very recently, I had knee surgery and I was bothered quite significantly post-surgery through, which we later found out on MRI scan, was a bone hematoma. And it's not something that I had particularly paid any attention to previously in physio, or I'd particularly heard of when I was doing vet nursing, but it looked pretty impressive on the MRI scan. And the clinician that was dealing with me said that this was a significant inflammatory response that they quite often saw post-surgery. So that was very interesting. And that caused me to offload and compensate quite dramatically. So I think, hematoma in the bone, particularly when you've got significant subchondral damage to the cartilage, is something to be borne in mind in terms of pain management and managing the condition, and how that then can affect counterbalancing and compensation. Failure of the implant, movement of the implant, rejection of the implant, and meniscal damage as well, and that can all then add to the mix in terms of compensatory factors. Quite often we see dogs that have had CCL surgery where upon completion of the surgery the meniscus is intact and they do really, really well in the rehab, and then 8 weeks later, 12 weeks later, 2 months, 3 months later, they present back toe touching lameness again. Don't appear to be horrifically sore, but abnormal gait pattern, compensating to the forehand, adverse spinal rotation, and we look at these dogs along with the referring veterinary surgeon and the orthopedic surgeon, and quite often we find that the dog's meniscus has now failed and a second surgery is required. So again, it's something to be borne in mind when you are looking at post-surgery dogs and looking at compensatory factors. If they have come sound, and then we get the compensatory gait pattern again in the same leg, to have a wee look at meniscal damage and meniscal failure. Counterbalancing. So counterbalancing is again related to compensation, and it is a gait pattern that animals will adopt to offload, and quite often we can't see it by eye, and it can be a shortening of stride, it can be a slight lateral or medial limb deviation, and that counterbalances a hind leg offset to the contralateral hind leg. And again, we then get, particularly in hind limb, a CCL injury and TPLO, we can then get issues with the other hind limb, which is why we certainly try our very best to rehab the surgical limb as quickly as we can, because we're very aware that the strain is being felt by the opposite good leg. We also, when we're talking about counterbalancing, we begin to see hypertrophy of the contralateral limb muscles. We begin to see hypertonicity and potentially contracture of tendons in the contralateral limb and the transverse limb as well. And again, we've mentioned previously before, we can quite often see biceps tendinitis starting to flare up on the forehand. Also ligament strain as well. We do see that more in horses with stifle injuries versus dogs, where we get manica flexoria issues and patellar ligament issues. But counterbalancing also opens up the window of abnormal loading of other joints. So again, with the counterbalancing, you may have a joint that's bobbing along quite nicely on the contralateral limb, and then we might very well start to see joint changes there because of the loading, particularly if it's long-term, where there's potentially just normal wear and tear in the joint, and that can be advanced quite quickly by counterbalancing. Lameness and offloading we've touched on, so I'm just going to skip through that because I've blathered enough about that in counterbalancing and abnormal gait patterns. Muscle, myofascial unit, tendon and ligament issues. So we've spoken briefly about tendon and ligament issues, so we'll talk about muscle and myofascial issues in a bit more depth, because that's what we're going to go into see in some videos in a short time. So muscle and myofascial units, we're talking about muscles globally. We're talking about gymnastic muscles and postural muscles and the fascial connections that connect all these units throughout the body. And I want you to think about this as a network, it's a system. So the way I try and describe it to clients is that the dog's tail is connected to the dog's nose, and the dog's hind paw is connected to the dog's front foot. And everything in between is interconnected. It's a big network. So if there is a dysfunction in the little toe, that will then have an effect on its front toe. We then begin to palpate muscle, and then we find things like hypertonicity, spasm, knots, or as we describe them, active trigger points. The fascia appears to be sticky. That's the superficial fascia that we can palpate from skin and the muscles. We get then contracture of muscles and fascia. So it becomes very, very sticky. And when you're trying to then move that soft tissue, you can't. It's very stuck. It feels very rigid. And then we begin to get a vesiculation in the tissue. And we quite often will find we've got active trigger points in the deep tissue underneath. We can experience strained musculature, and I suppose the very worst end of the spectrum would be micro tears and bruising. Quite often as well, we will describe muscles as being filled. And what we mean by that is that there's a bit of soft tissue effusion within the actual muscle belly. And that is, again, related to hypertrophy of the muscle and the muscle being overused. You know, it's never getting switched off. It's being used all the time. Doesn't get a break, doesn't get to relax. And then we begin to see a muscle dysfunction. So skeletal and joint issues, again, I'm not going to labour that point because we've spoken about sort of degenerative joint issues, osteoarthritic changes in other joints, and how that can be accelerated from long-term compensation if it's already there, or it can be introduced into a joint if it's not already there. Proprioceptive deficits, again, that comes in, you can have proprioceptive deficits due to muscle dysfunction, due to fascia dysfunction, due to joint dysfunction, and obviously from a neurological perspective. And that will also
say that because often we always think of proprioceptive deficits being due to a neurological issue, but they can happen because of other reasons as well.
Yes, absolutely. Yes. You can, in fact, actually, I've got a couple of analogies, but I'll pop them in later on. You can quite often get non-weight bearing or toe touching issues from, for example, torn iliopsoas muscle, and certainly offloading, and sometimes that can be mistaken for, you know, initially cruciate ligament injury. So it's just to bear in mind that it's the network of you know, the joints, the muscles, the skeletal system, it's everything working in harmony as one. And if one part of that has a dysfunction, then it has a knock-on effect right through the system, you know, through pelvic limbs, through the trunk, through the thoracic region to the cervical region. Right, I think we're... So, first video, let's see if I can play this.
Yep, that's great.
Okay,
that's
that. Okay. So this is a reasonably geriatric dog. It's 9. It's had both knees done, so it's had TPL surgery on both hind limbs. And the reason I've popped this video in just now, it's well past its surgery. The reason I've popped this video in just now is that you can see there's reduced flexion in both stifles. He's compensating everywhere. His gait looks absolutely horrific. His toes are widespread because he's offloading to the front. He's plantigrade. He's a wee sausage. He's obviously got arthritic change pretty much everywhere. He's got proprioceptive deficits. So you can see that this animal is compensating quite significantly through his pelvis. His tail carriage is low and static. He looks to have more of an involuntary gait pattern than a voluntary gait pattern, if that makes sense. He's wide base gait on the front, elbows out. And
very unusual because it almost looks like he's sort of trotting at the front and then very wide behind, abnormal, sort of almost like he's falling on his back legs.
Yeah. So he's on the forehand. He's ataxic. Well, he's mildly ataxic behind, and it's more of an, you know, it's more of an involuntary movement behind, isn't it, than in front?
Yeah.
But you can see he's a good picture to show you, because you can see that there's no muscle movement there. You know, his muscles are very, very tight. His fascia is very tight. He looks really stuck down all over. And that's what compensation can do. You know, that this is what we're looking at in terms of a long-term compensation. This was the first visit that this dog had to us. And this is our initial assessment, so we had an awful lot of work to do with him. But he hadn't been rehabbed post either TPLO surgery.
This is what, a few months on, or a few years on?
This would be, his last surgery would have been 8 months previously. So I think one of the big things that certainly I became aware of when I started down the path of veterinary physio was, and coming from a vet nurse perspective, and I suppose from myself getting older, pain is a factor that I think is always there. And in terms of when we're looking at dysfunction, you know, I'll quickly populate this. So tendons and ligaments, affected joints, altered gait pattern, neurological, other joints, and muscles and fascia. These are areas that you can get pain from individually. So, you know, if you've got a ruptured CCL ligament, you know, that's going to cause you pain. You're going to get inflammation from the affected joint, which is going to cause you more pain. You're going to have an altered gait pattern because you're in pain and you're offloading, which is going to cause you more pain on the forehand or through the back. You've got the neurological element. So again, we've got the micro element and we've got the macro element in terms of neurological involvement. You've got pain from other joints that you might have had a niggle with previously, but haven't really bothered you, but now they are bothering you because you're offloading to that joint. And then laterally, you've got the muscles and fascia, which get tighter and tighter and tighter because nobody's released them off and nobody's paid any attention. And I think as a vet nurse, you know, when you have a dog on the table and you, as a veterinary surgeon, you're doing the surgery, a vet nurse, you're assisting, and you repair that cruciate ligament, and the job's done, and the animal survives the anaesthetic, and it walks out the door to its owner. That's our job done. We're done. The surgery's been finished. Away you go. And a lot of the time, you know, there's a exercise a plan put in place, which will involve crate rest and out for the toilet for no more than 5 minutes for the first 6 weeks. And then thereafter, walks of 10 minutes on a short lead. So straight away, any compensatory factors throughout the MSK system that are there pre-surgery are still there post-surgery and then have been added to. And then we're imposing crate rest with minimal exercise, which helps to contribute to that compensation because the animal is now static, so it's the other joints aren't getting much in the way of active range of motion, and the muscles and the fascia become even more stuck down, which creates more pain. And quite often then, when we see the animal, you know, when I first do a physiotherapy report, and we're listing down all the muscles that we've released off or that we've found tight or the fascia that's been inhibited, the picture looks quite grim. But that's not the dog, you know, that's the dog's original baseline from all the compensation and all the offloading that it's been doing to facilitate some kind of normal function prior and post surgery. So I think it's important that we as an industry, vets, vet nurses, physios, massage therapists, chiropractors, as an industry, we begin to look at these animals globally. It's not enough just to do the surgery and say we've fixed it. So we need to address the pain. So initial management, acute phase, obviously analgesia through your registered veterinary surgeon or orthopod. Ice initially is something that we can all do, and the owner can apply ice as well. Heat for muscles. So if the muscles and the fascia are tight and stiff, then we want to apply some heat there and then some gentle massage. Laser therapy. manual therapies and other electrotherapies. So laser therapy, obviously, from a vet nurse, veterinary surgeon or physio point of view, or somebody else that's trained with laser. Manual therapies, you know, we can give clients instructions to give the animals nice manual massage. And I think I would be right in saying, I remember we had an open day here at the clinic a long time ago, and it was very obvious that attending vets didn't have an idea of what we did as physios, and I think that's potentially come from their own experience of perhaps seeing a human physio whereby there was exercises given for the affected part of the body. Because my own experience of a human physio when I had my knee surgery was, we will just deal with your knee, we won't deal with everything else. So I think it's very important, again, that as an industry, we look at the compensation factors and the MSK, the way the MSK has to function to look after the injured area, the injured limb, and the changes that happen to the muscles and the joints everywhere else in the body. So manual therapy is very important because we can give the owners massage instructions to the forelimb, to the neck, to the thorax, to the back. It'll all help the animal feel better. It gives them a bonding opportunity, particularly if the animal's on crate rest. They don't need to touch the affected leg. You know, they don't need to touch the sore bit, but they can certainly help everywhere else. And we can use other electrotherapies. Caroline in her talk at the end, was it last week before?
I think it was a couple of weeks ago, yeah.
Had mentioned other electrotherapies. So we've got pulse magnetic field therapy, TENS machines. You know, an owner can be set up with a PMFT unit or a TENS machine to use at home. We've done that quite successfully. Owners want to help their animals. So, you know, get them involved, and at the end of the day, they're seeing their animals struggle. And quite often, if you ask an owner, you know, how's the animal managing to rise from resting, the owner will say, oh, you know, it's dragging itself up with its front legs. There's a clue, you know, it's going to be sore in front because the animal's dragging itself up with its front legs because its hind limb's sore. So again, getting the owners involved, and if you don't know how to massage, there's loads of techniques out there online. Gentle massage, there's the Canine Massage Association. They've got lots of stuff up, and so does CAM. You know, Canine Arthritis Management. They've got loads of information on their site as well about manual therapy that can be passed on to owners. So any other questions at that point?
Not from the audience as far as I can see, but I just wonder, in terms of, obviously, you know, non-steroidals, analgesia will be on board and then hopefully tapered down as things become more manageable. Yep. The other was, in terms of ice, heat, laser, manual therapies, are you going to be throwing everything at the case from the beginning, or is there a certain order? I imagine the ice is going to be more useful in that acute phase, and when there's inflammation, obviously, around the joint or post-surgery.
So ice is obviously acute stage. Heat you can use in the acute stage for contralateral limb muscles, or across the pelvis, for example.
And then, of course, you can use laser on both of those. You can use laser for inflammation and then also for muscle pain as well.
Yes, and muscle contracture. So, and we're going to go into that just shortly. So, and here we are.
Oh, there we go.
So, I've tried to break this down in terms of treating the affected joint, and I don't want to go into this into too much detail because one of the talks we're doing is is about TPLO. So we'll go into that in more depth. And this is more how the rest of the system compensates and functions post TPLO or CCL surgery. So laser application for the affected joint. Post surgery, if the animal is hospitalised, you're looking at twice a day or even 3 times a day, if possible. And then you want to transfer on to 3 times a week and then down to twice a week. That obviously is a case by case prescription, if you like.
Yeah.
Initially, you want to treat for healing first and then for pain. So for joint, we would have the post-surgery joint setting. Most of the machines now, particularly class 4s, as the MLS ASA Vet Orange has, it's all preset with your different settings, which is very good. And all we need to do then is decide the type of skin colour that we're dealing with. And as a clinician, you then need to decide, is it acute phase, is it chronic phase, or, what have you got in front of you? So initially post-surgery setting, then your wound or your infected wound setting. The one thing I will say about this is you will need to check, the animal will obviously be on antibiotics, and you need to make sure that the antibiotics you've given the animal are not photosensitive if you're using laser. Edema, acute inflammation, OA. I've put OA in there and chronic inflammation because quite often we do see joint changes already in the joint post after the initial cruciate ligament injury due to the instability, and then obviously chronic inflammation dependent on how long that joint has been unstable for, and then lastly around the joint for pain. For the muscle and the fascia, and this is where we start thinking about the compensatory factors. So the stifle doesn't operate by itself. There are muscles and tendons and ligaments that are attached to the stifle, and we can't forget about them when we're treating initially post-surgery, because they will have been compromised due to the initial injury and then due to the surgery, the surgical intervention itself. So then we need to look at if we've got any tendinopathy, trigger point potentially for muscles and fascia. If the sartorial muscle, for example, which we quite often find is grossly contracted upon injury of the CCL, so you might want to look at trigger point therapy or trigger point setting on the laser unit. Muscle contracture. Do we have a muscle strain or sprain of tendon or ligament? Again, inflammation. So do we have soft tissue effusion in the muscle belly? If so, we want to look at an inflammatory setting for that. And do we look at acute or chronic inflammatory setting? They both operate slightly differently. And then again, pain. So if we are looking at treating the joint immediately post-surgery, I would use the joint settings. I would also then have a look at, I quite often like to see these dogs sort of 72 hours post-surgery if they're not hospitalised. So if they've come home, I quite like to see them 72 hours post-surgery. And what I'm looking to do at that point is attend to the muscle, the fascia and other joints, and I always treat the joint above and below. So obviously if it's stifle surgery, I'll look at the hip and I'll treat the hip. I'll also look at the pelvis and I'll also treat the hock. Because the whole limb is compensating. You then want to look at the contralateral limb as well for any compensatory issues that you can find there. So if we're talking about muscles and fascia post-surgery from a compensation perspective, we're going to have a mixture there of probably acute inflammation and chronic inflammation, because that, for example, the sartorial muscle has been working very, very hard. The quadriceps have been working very hard. The gluteals have been working very hard on the affected limb. Cranial tibial muscle has been working very hard. So you want to look at identifying these muscles and treating them. And I generally, if they've got trigger points in them, then I would use trigger point setting first of all, and then generally chronic inflammation setting, and then muscle contracture setting, and then manual therapy to work through the musculature, and then joint mobilization and stretching for the muscles. We want to try and get on top of the compensatory musculature as quickly as we can. If a muscle is contracted, then no matter how successful the joint surgery is, the animal will not mobilize properly because it can't. You know, muscular tendinous junction is contracted, then that animal can't function properly with the limb. The biomechanics can't function properly. So we need to concentrate on that. We need to look at that as part of the overall rehab. Right, I think now we've got, yes. So I'm hoping that this is a little series of videos. Now, this was a TPLO. This dog saw it last week, I think. Black lab. It is overweight, which is another compensatory thing we've not mentioned yet. So this dog is now 13 weeks post-surgery, and it first came to see me last week. And we'll see if we can get this video to play. So first of all,
is that an orthopedic bed you have them lying down on?
It's a specialised physio mat that I had made. I've got two of them. So here I'm using the laser therapy and it's acute inflammatory setting that we've got here. I'm just moving it round the joint. So you don't want to keep the joint static when you're applying the laser. You want to mobilize the joint so you can access the joint surfaces cranially, caudally, laterally, and medially. This dog was referred because 13 weeks post-surgery, it's still toe touching. It wasn't wanting to load the limb properly. And the next video, I think, should be me doing just very gentle joint mobs. This dog did not want to flex its knee at all.
I could see it didn't want to straighten either. No. There was very little. And is that partly to do with the muscles that have just sort of seized up?
It's partly to do with muscles, but I mean, she effectively hasn't really used the limb. You know, it was described as a peg leg, and she was very static through her range of motion when I first looked at her, and she was guarding. And this is the first time actually I've lasered this dog, so that's one lot of acute inflammatory response, and we were able to joint mobilize. We then go on to, oh, that's the same video, sorry, hang on.
I don't think it is. I think it's
no, that's a different video. Yeah. So we're just increasing the joint range of motion. And she's very relaxed. The other thing as well that I've certainly found with the laser, the dogs are very accepting of it. They're very relaxed. They know it feels good, so they're quite happy to allow you to use it and then mobilise and work on other tissue and muscles. So now I'm just starting to work on the musculotendinous junctions and the patellar ligament. So once the way that we work is once we've looked at the actual joint mechanics, we then start to look at the attachment mechanics. So I'll work my way through sartorius, quads, so, and again, lateral, medial, quad vastus, tibialis muscle, and then go down to the digital extensors as well, particularly because this dog had been toe touching. So she did have quite a lot of contracture. You can see the difference there already.
And this is all on the same day, on the same session that you're doing.
Yep.
It's not
Yeah.
days. Yeah.
Yeah.
So it must have really helped just easing that. I mean, even when you first were putting the laser on there, you couldn't get as much flexibility as you can even now.
No, not at all. Because
that sort of loosened everything up and allowed that.
So I thought it was actually quite good when this little dog came in, you know, just given the state she was in, to be able to show you, because we obviously see this day in, day out. But it's
not
good.
because of anything that went wrong necessarily with the surgery.
No, I think she's just...
There was no further surgery that was needed.
No,
the surgery itself was a success.
Yeah,
but it was the fact that for whatever reason she became very couldn't flex it properly. All those compensatory things that we've been talking about because of the pain, the inflammation, and all of that. Got to a point where
she was very, very tight. You know, her hip flexors were tight. You know, she was really rigid through her back. You know, she was tight in her neck. She was tight all over the wee soul. And she's 4.5. She's not an old dog. But she had just stopped using the leg because everything was so tight. And you'll see in a wee minute, in one of the next video, I think it is, I go into the hamstring group, and you can see the trigger point firing, and we laser it, and you'll see the result of that.
Oh, that's interesting. So you can see her reaction when you touch the trigger point. We have got a question here.
Yep.
I'm not sure who it is because I can just see the Facebook user here. But hi, is there any scenario where you would choose to use manual therapies before electrotherapies with cranial cruciate ligament repair?
In terms of joint or in terms of compensation factors?
I think it was, you know, maybe we were talking about those sort of passive range of movements and extensions that we'd give an owner, perhaps in that immediate sort of post-operative to pet.
Okay, so in terms of giving the owner something to do, then I wouldn't particularly have the owner doing anything with the affected leg to start off with, unless they have been given and shown correct passive range of motion by the orthopod or the referring vet, or, you know, a physio attached to them. It's very dangerous, I think, to give owners, you know, to sort of say to owners, oh, you can do passive range of motion on it, you know, just bicycle the back leg or something like that. So if the owner has been versed and has been demonstrated in it, what I do with my owners is that I will show them what to do. I will ask them then to do it, and then I'll video them. I'll video myself doing it, and they'll get that home. So it's their dog, because obviously every dog's different. It's their dog done to the range of motions performed to the range of motion that their dog can manage at that particular moment in time. And that is reviewed and reassessed at every visit. Okay. In terms of the laser, when we looked at this particular dog, she was so sore globally that it wouldn't have been it wouldn't have been professional of me to do anything other than put the laser on this dog to start off with before I started doing anything with the joint at all. She, you know, immediately, as soon as you touched the leg, she was lip smacking, she was looking around, she was very uncomfortable. And we don't want the dogs being uncomfortable, particularly not from a physio point of view. And I did mention this the very first chat we had. We need the dogs to be as relaxed as they can be, so that when we're palpating, we know that any hypertonicity that we are identifying in the tissue is coming as a result of compensation and not their mentation, and not the fact that they're worried or they're stressed about anything. So I shall move. I think the next video will be. So this is muscle contracture setting that we've got on just now. And I don't know if you can see just at her upper semitendinosus at the hamstring, you'll see it keeps firing just when I'm extending the leg forward, just sort of above where my thumb is.
Just sort of flickering.
Yep. And the hamstrings have become quite contracted, just the fact that the dog's been toe touching and not extending and flexing the limb properly. And it does take a bit of time, you know, when you're working through the fascia and the muscles. It does take a wee bit of time to allow the tissue to assimilate the information it's getting.
It's funny because you can tell the dog is relaxed, but equally there's that little bit of tension with the little bit of panting and things. You're seeing more with the manipulation, isn't it? Because obviously these
well, that and the fact it's the first time the dog's been in the building. Its owner's not there, because we're not allowing clients in the building either. You know, nobody's holding the lead. She's quite happy to lie there. But so you'll see the hamstrings here now. You'll see there's very little tone and definition in the musculature in that hind limb, and she has lost quite a bit of muscle from her glutes as well. And it's quite interesting because the owner thought we would just put the dog in the underwater treadmill in the first session. Right, this is the hamstrings now. So a bit of manual therapy just to start mobilising the fascia and the tissue. And you can see there the trigger point starting to fire. And dogs aren't, you see them there. Dogs aren't very good at, some dogs you can manually release trigger points, but I do find the laser is my go-to for muscle contraction and trigger points in dogs, because they can be very sensitive, whereas a horse, you can, they're much more adaptable to releasing trigger points manually. And when we're looking at the hamstrings, we come right down the calcaneal tendon, right down the Achilles to the hock. And this goes back to what we discussed earlier about, treating above and below the joint that's affected because the structure in that whole limb has been compensating.
And so there can be trigger points all the way down throughout that muscle and throughout all those hamstrings. Yeah.
Yeah, particularly, if the dog's been toe touching, and obviously this has been toe touching pre-surgery and post-surgery. And there was a delay with the dog having surgery because there's a delay, for appointments just now post-COVID and things like that. So the dog had been struggling with the injury. And again, it's a good idea, if as a veterinary practice, if you've got a registered physio locally, that these dogs pre-surgery go for a work through, just to help get rid of the musculoskeletal issues. You can see that's still firing, so I'm going back in with the laser again.
And I think particularly when we're using the muscle settings, you've been using scanning mode rather than point mode. But even when you were actually treating the joint before, I know you weren't quite as mobile and moving with the actual head. Were you actually using point mode at that point?
I was using point mode.
Yeah, but you weren't, again, just hold absolutely stock still.
No, I was working around the joint. I've certainly found that gives me the best results.
Yeah.
Rather than holding the head on static in one position for the time duration. Oops, I think I've just moved that.
Those were fantastic videos.
Okay.
Be able to see that triggering of the muscle. You could see just with that gentle, even that very gentle palpation, you could see the whole muscle going into spasm and releasing after you'd used the laser. Really good.
So next, this is just I've put this one in because it's a fantastic, obviously, as we've discussed throughout tonight's discussion, the compensatory muscle factors will occur through contralateral limbs, transverse limb, right through the back, interscapular caudal border, scapular latissimus dorsi, your back muscles. And we had this chap in, again, just to show you what a trigger point looks like for anybody that doesn't know what a trigger point looks like.
So how much pressure are you actually putting there on that?
Not a lot of pressure at all. Probably,
just a sort of nudge, really.
Yeah. Not enough to make a dent in a block of butter out the fridge.
Yeah,
that's right. I always describe to students that if you're releasing a trigger point, because it's not nice, it is uncomfortable, that you're using direct digital pressure, and what you're looking to do is blanch that trigger point of its blood supply in order that it releases and relaxes. And the analogy I use is if you were to take a block of butter out of the fridge and it's cold and you put your finger or your thumb on it, you just want to gently hold your finger or thumb there until you start to feel that butter melting under your fingertip. And that's exactly what you want to do with a trigger point. And there's another wee video here because he's got one on the opposite side. And I put a bit more pressure on this and you'll see what happens. So he's looking round, he's not happy, and he tries to get away from me.
Yeah.
And that's just applying a slightly more pressure, which is why laser therapy is fantastic for these dogs, because you can straight away apply the laser unit on trigger point setting and release that trigger point without causing that. So this is me back to the original trigger point on this side now. And I'm using trigger point therapy. And again, what I do is I'll just very gently massage. I'm using direct contact, so it's a point therapy, but I just very gently just massage clockwise, anti-clockwise. He's quite happy with that. It's not, it's not upsetting him at all.
And was this because of a forelimb injury?
No, this is a hind limb. He's got hind limb issues. He's another another dog that comes for it's sort of osteoarthritic management, mobility issues. But I just thought it's a very good one to show you of, an active trigger point that you can visibly see.
Yeah.
And again, it's actually quite easy to feel with the laser when the trigger point starts to dissipate. It moves, the point moves, and then there's much more mobility underneath the head because you're causing obviously vasodilation. You're opening the blood supply up, and the fascia starts to release, and the muscle starts to move underneath it.
Yeah.
So again, it's quite easy to see that with the laser. And this is just another point above the one we were on. So really across his interscapular strap, he's riddled with trigger points from compensation.
It's really good to be able to see that being released and how relaxed he is when he's having the treatment.
Yeah, he actually did fall flat asleep after we finished. So it's just, it's really a case of when you're using a laser, don't be afraid to be mobile with it. You don't need to hold it static in one position, even if you're on point to point. You can use it almost to massage. And the dogs really, really enjoy it. They love it. And you can just release that tissue off. And other than when I came off that trigger point, it was completely gone, and I just effleuraged the tissue. So I just activated the lymph system, and that was it. I didn't have to go in and do any further massage in that area then.
Or any further laser or anything in that whole muscle. Yeah. As opposed to that hind leg that we were seeing that had those trigger points, and actually it also needed some muscle contracture laser there because it was a much more chronic issue.
So I'm just making sure that we've got everything away. And then a bit of effleurage, job done. So that's laser release without really any manual digital pressure at all for the trigger point. Very effective, and the dog's quite happy with that. And you see that the whole tissue surrounding that area is now much more mobile than it was. So by releasing that active trigger point, you've then had a positive effect on releasing the surrounding tissue as well. So that's just to show you. I think everybody's got different machines, but it's the MLS ASA Vet Orange that I've got, and we just use muscular contracture. It was on the point-to-point setting, and phototype was W, and that was only on a small area setting to have that effect. So
And I think it's about in the region of sort of 2 to 4 joules per centimetre squared, isn't it? Something like
yes,
that.
it is.
Relatively low dose, but it still has really good effects.
Yeah. So laser treatment protocols, I've just popped these in. This is obviously what we use there. So direct head application, but we kept it moving in a sort of massage, like a therapeutic massage motion. The first setting we used was trigger point therapy. So it's 1 joule per centimetre squared. And it's 25 bursts of 25 seconds. The setting 2 is muscle contracture, and that's just coming in under 4 joules per centimetre squared. Very quickly, because I think we're running out of time, are we? Subacute management. So treatment of the surgical site to start off with. Laser, passive range of motion, and please pay attention. If you've got laser units, use them to the musculotendinous junction and the muscles. You always want to assess adjacent joints for overuse, pain and inflammation. You want to look at activating the muscular chains, targeted release using range of motion and stretch work. Think, please, about focal adaptations and global mobilization for the animal. You know, how can we get this dog to move properly? Because the quicker you can get it mobilizing properly and effectively and efficiently, the less compensatory issues you're going to run into. And then lastly, dynamic movement patterns. So your active range of motion. What can you ask the owner to do at home that will help to correct any compensatory patterns in this dog? And that can be something simple like asking the owner to do sit to stands or sit to downs correctly, so the dog's not scrabbling forward with its front end, pulling its back end up. And there can be assisted exercises as well. I'm quite sure I'm very fortunate where my clinic is. I've got some great vets round about me that I've known for a long time, and you know, I know if I need help from them, I just need to ask, and it's the same. You know, if they have a patient that doesn't want to come for physio but they're looking for exercise prescription, then they know just send an email and we'll put a plan together based on what their requirements are.
Yeah, and that's something that, you know, connections is what we want to foster here, you know, within the group, because we've got a whole range of different levels of experience. So we've got veterinary physios who are just starting out. We've got student vet physios. We've got students vet physios who've been working all around the country and internationally for many years. And actually then there's vet nurses who are getting into rehab, vets who want to do the best for their patients, but perhaps wouldn't necessarily have the same level of skill on the manual therapies and all of that. So reach out, you know, if you've got people locally, or you want to find someone locally who you can work with or alongside, and it's a mutually beneficial relationship for, you know, your patients as well. Yeah.
Well, I mean, that's the thing. And with today's technology, you know, it's not any bother to send a video showing, showing exercise or whatever. So I'll pop this little video in, and it's an exercise we use that I think would be very handy for veterinary surgeons, vet nurses watching. Physios should know what this is. It's rhythmic stabilization, and this is my little dog, Lily. She has nothing wrong with her, so she's just been a victim in this picture. But the reason I'm putting this in is to show you how to isolate the glutes and the sartorial muscle and the quadriceps. So hopefully I can play this little video. So I'm just rocking her gently backwards and forwards. She's not happy. And if you look at the left hind quarter and the left hind limb, good lass. You want to make sure, if you are giving this exercise to any owners, you want to make sure that the hind limbs are as square as possible. You want to make sure that the forelimbs are as square as possible. Can you see the muscles there just contracting in that hind leg?
Yeah.
So it's a really, really good targeted, and we're going in for the close-up, it's a really good targeted exercise. You can see them pumping away there. And this one should be a close-up. There you go.
Oh, yeah, look at that.
So that's a really simple exercise, you know, that owners can be given at home to do immediately post-surgery, you know, sort of certainly 72 hours post-surgery. There's not an issue to do that, which just starts to fire your the stifle tendon group and the quadriceps and gluteals, etc. So that's a really good exercise. If you are doing that exercise, you want to start off at about 10 reps, give the dog a break, and then another 10 reps later on in the day. And then you ideally want to build it up to about 30 reps per sitting. And I've just some quick slides to finish. This is more advanced stuff in terms of exercise that we can use to actively stretch the musculoskeletal system, basically. So we're not particularly looking to identify any stretching of a particular hind limb, but they're just really good exercises. So it's to give you sort of thoughts that you can discuss with your owners, you know, post-surgery.
Introducing a little bit of a soft surface there to switch on the core muscles and help with conditioning and rehabilitation as well.
Yeah, so we've got a contact board, we've got a half wobble cushion, which are really quite good because they're sturdy underfoot, and we're also using a pebbled area, so that's quite good proprioception as well. And then we've got positions on the board, a beg position, which is really, really good for dorsal ventral spinal flexion. And then we've just got some other clips here of different exercises. And these are really sort of good global exercises to do. Pole work, which we've all heard of that and done that. And then the hula hoops are quite a good idea for proprioception.
Thank you so much, Rachel. Absolutely amazing videos there of the trigger points, seeing the laser in action and actually seeing it being used and the techniques you use to, I think we talked about some of these techniques before, but actually to see it, I think that will be really useful for those, new to using laser. And just how versatile it is, really. Thank you again, Rachel.
No bother, my pleasure.
All right, I'll see you again soon. Bye.
Bye.